Good morning, everybody. Good morning, surgeons. It's my pleasure to introduce my senior, Dr. Omar Lattouf, a well-known figure in thoracic cardiac surgery in USA and Jordan, and he believes in teamwork. He has a team of surgeons in America and also in Jordan, and his talk will be teamwork and complex cardiac intervention. Welcome, Dr. Omar.
دكتور علي, thank you very much. صباح الخير لكم جميعا. دكتور إبراهيم, تحياتي وبهنيك على نجاح هذا المؤتمر العظيم. The punchline in my talk is not surgical. Actually, it's interventional. And it is the capacity and capability of interventional cardiologists saving the day. That's my punchline. And how, for me, as someone who has been doing complex heart surgery since 1985, and I humbly say I have been involved in doing personally over 10,000 heart operations, and I have cared and managed and so on well over 100,000 cardiac patients. I faced a situation that brought me down to my knees. And it took me 18 hours to solve, but it took a cardiologist to save the day. And it was a teamwork with multiple people who were involved to make that patient cross the line and survive an exceptionally complex situation. And that situation was so complex that I called my other experienced cardiac surgeons and I said, I'm facing so-and-so in a patient who has aortic dissection after I successfully repaired that. He said, you and I have done well over 400 acute aortic dissections, but we have never encountered that situation. Are you sure you want to do what I will tell you in a minute, what we did? So that's the situation. And let's go through the process and discuss it. It takes really a teamwork to accomplish anything that we do. It is not what I can do. It is what we can do. And I have learned over the years, truly, that good work is the result of each and every member of the teamwork to do. Whether it is the anesthesiologist, the cardiologist, the surgeon, the assistant, the nurse, the pharmacist, because anyone who makes a mistake across that chain line, your work will be derailed. And when I came to Jordan between 1994 and 2000, with the good help of you all, we established an excellent team. And we had very good results, and I am proud that I have. The American College of Cardiology has written a paper that it takes a team to deliver optimal cardiovascular care, and I truly believe that. And that team is not just the physician, it's not just the surgeon, it's not just the cardiologist. It's the advanced practice practitioners, it's the nurse, it's the technologist, it's the administration, it's the pharmacist, it's the allied health. It's the lady and the gentleman who clean the hallways and keep the hospital sterile. I know each and every cleaning lady and cleaning gentleman in my hospital, and I greet them by name, and they greet me by name. And there is for me, that gives me that personal satisfaction, and it makes me feel that we all are on the same level. The American College of Cardiology in its affiliate program has listed the numbers and percentages of team members who participate in cardiovascular care. And I hope, Dr. Mahmoud, that in the next conference, you will have as many nurses and physician assistants, respiratory therapists and pharmacists and so on participate in this fantastic conference that you have done, because they must feel that they are part of the game. I'm not sure that there has been a single war that has been won in the history of mankind where only generals fought. It takes foot soldiers. And Dr. Mahmoud, your foot soldiers are your nurses. They must feel that they are as important as you and I are. In my hospital, I know all of my nurses. They know me. We go by first name. And when they call me at 1 o'clock in the morning, I get up and I go on an address, and I never disappoint them in our work relation. Michael Jordan is probably one of the greatest athletes who have ever lived. He said, talent wins game, but teamwork and intelligence win championship. I think I can say humbly that you and I are probably talented to get to this point, but it's not you and I who can reach the finish line alone. Isaac Newton, he said, he accomplished what he did by standing on the shoulders of giants. And I think that is true for all of us. Harry Truman, whether you agree with his politics or not, is recognized as being one of the greatest presidents in the United States. And he said, it's amazing what you can accomplish if you do not care who gets the credit. And trust me, if you do get work and you deny yourself the credit, others will bestow that credit on you multiple times more. وما في أعظم من كلمة ربنا سبحانه وتعالى والذي قال في سورة التوبة وقل اعملوا فسيرى الله عملكم ورسوله والمؤمنون وستردون علم الغيب والشهادة وينبئكم بما كنتم تعلمون صدق الله العظيم. Do as you will. Your deeds will be observed by Allah, His Messenger, and the believers, and you will be returned to the knower of the seen and unseen. Then He will inform you of what you used to do. This has been my guiding line. This has been my guiding principle. وَقُلْ اعْمَلُوا فَسَيَرَى اللَّهُ عَمَلَكُمْ وَرَسُولِهِ. I faced a situation 2 months ago when I had a young man, 50 years old, with history of hypertension, bipolar disorder, substance abuse, who was found down in Central Park in New York City. For unknown time, he was picked up by the emergency team, brought to the hospital. He had altered mental status. My intensivist called me. She said, this patient had CTA. He has an aortic dissection. He's confused. He's ripping his aortic arterial lines. We have to intubate him in order for us to be able to put the rest of the lines. And he needs to go to the upper room right away for treatment of aortic dissection. Okay? Every surgeon in this room has encountered that situation or a similar one and has done an excellent job. Nothing particularly special. So here is the CT angiogram on this patient, and the first abnormality that we saw was that the right subclavian artery originated from the left side of the aorta. That was the first curved ball that I encountered. Usually the right subclavian comes from the innominate, the first branch of the aorta. This one came from the wrong side, and I did not know that until I am in the midst of the aortic dissection when I did a cut down on the right axillary artery in order to cannulate it. That's how I perform my operations. To find out that the axillary artery is dissected, so I had to abandon that approach, and here is the dissection you can see. I had to abandon that approach and go into plan B. So we performed the following operation. We did an emergency operative intervention, failed to cannulate the axillary artery, cannulated the lumen of the true lumen of the aorta under direct transesophageal and direct echo, moderate hypothermia. I placed cannula in the great vessels directly and perfused oxygenated blood into both the right and left carotid, replaced the ascending aorta, resuspended the aortic valve, corrected the aortic insufficiency, and tried to come off bypass. We tried to come off bypass. Patient was in VFib, VTAC. It took me literally 14 cardioversions to get this patient back into sinus rhythm. I never have encountered that situation, so I knew we have a problem. I didn't know exactly what was the problem, but there was a problem. Finally, we were able to get him back in sinus rhythm. So operation started at 12 noon. Now it's 6:30 in the evening. I'm done. I'm happy. I break scrub. I leave. At 8 p.m., my resident calls me. He said, the blood pressure is dropping. And as she's telling me the pressure is dropping, she says, oh, you need to come right back. He is in VFib again. So I go back to the upper room. She's CPRing my patient. He's in VFib. We cardiovert him. My anesthesiologist, Samit Kia, who's an outstanding young man, manages his patient, and after 25 minutes of CPR, he gets him back in sinus rhythm. I said, Sam, please do a TEE again. Let's see if the aortic valve is working. Can you see the left main? Can you see the RCA? Is there pericardial effusion? He says, everything is fine. Should I open him up again? I said, no, he is on no inotropic support, doing well, let's take him upstairs. So we go upstairs. Now it's 9 o'clock in the evening. I go home. I live 3 blocks from the hospital. I'm about to sit for dinner. My resident calls me. She said, he's dropping his blood pressure again. In fact, he arrested. So I go back to the hospital, and she has successfully CPR'd him after 30 minutes. So I called the upper room team back and said, I think I need to take this patient back to the upper room. We do another TEE, everything is fine. So we said, okay, let's hold off. A few minutes later, he arrests for the 3rd time, and we CPR him, we bring him back. So we call our cardiology fellow who's in-house, and we do this EKG. The cardiology fellow says, your patient has ST segment elevation myocardial infarction. I said, well, what should I do now? He said, well, by definition, ST elevation MI needs to go to the cath lab. So I called John Pascas. I said, John, I'm in trouble. I just finished this procedure. He says, Omar, we've never dealt with this situation before. Just treat him medically. I said, John, this patient has died 3 times today, and I have an EKG with ST elevation MI. I'm going to take him back to the cath lab. I called my cardiologist. Now it's midnight. Woke up my cardiologist. Let's take him to the cath lab. Well, at midnight, it took quite a bit of convincing. I had to say, it's either you come now, or I'm going to call an ambulance and take him to another hospital. My cardiologist comes. She could not engage the right coronary artery. We call another cardiologist from across town from the main hospital. And as we're speaking with him, said, we were unable to engage the RCA. The left main is abnormal, and we need your help. And as we're speaking with him, the patient arrests for the 4th time. So I drop the phone, I go to perform CPR again. And as we're doing the CPR, the cardiologist from across town comes without further ado, and he comes and he participates with us. He injects the RCA, brilliant young cardiologist, 1st time. So the student really outplayed his professor, and within 2 minutes he engaged, found lesions in the RCA, went to the native LAD, found a lot of disease in the native LAD, the circ is totally occluded. So he proceeds to perform very complex PCI. The circ is occluded, the LAD has 95% lesion, the RCA has lesions. He PCIs the LAD, the circ is chronically occluded, he PCIs the circumflex. He saves the day. Start him on Cangalore, the next day he's weaned and extubated, switched to Plavix, transferred to the floor 5 days later, and the patient survives. Having seen it before, done it before, been in complex aortic dissections, have been in complex situations. This was the first time that I found myself in a different new scenario. And it truly was, if it wasn't for the outstanding resident, the outstanding anesthesiologist, the outstanding team of cardiologists, everybody. Started an operation at middle of the day on a Thursday, finished it at 6 o'clock in the morning on Friday. I was worn out, everyone else was worn out, but that patient walked out of the hospital alive, starting with an ejection fraction of 20%, going home with ejection fraction of 60%. It really takes a teamwork to accomplish what we need to do. And anyone who thinks otherwise really has not done enough, hasn't been around the block. All of us have paid the big price. Good team work will bail you out. Thank you so much for your attention. It is my pleasure.
Thank you, Dr. Omar. Our next speaker, Dr. Abdul-Hakim Dayeh, cardiac surgeon at Jordan. He'll talk about updated invasive cardiac surgery. Welcome, Dr. Abdul-Hakim.
شكرا دكتور علي. صباح الخير جميعا، جمعة مباركة. It's a pleasure for me to present you more updates or the latest updates in the minimally invasive cardiac surgery, which was a very hot topic this year in the European meeting in Milan. So the minimally invasive is now fast growing to very important reasons. The most important one is that the patient desire. The patient want less invasive procedure, more cosmetic result, less ICU stay, and better outcome. So also the literature show us in the last decades better results in the minimally invasive surgery. Even Joseph Lamelas in USA, very interesting and nice result in the difference between sternotomy and minimally invasive surgery. Also here the Leipzig group with more than 1,000 patients with excellent results in 10 years. So I will present you today cases on our daily practice and not something from outside. He's a patient with 60 years old with severe MR, bileaflet prolapse with ruptured chordae, almost a flare from both sides, eccentric jet from both sides, which we treated with minimally invasive mitral valve repair. As you've seen, also in this complex case, we can do minimally invasive repair with nice result, nice complex, a nice cosmetic result. The minimally invasive CABG is a new approach in the minimally invasive surgery, but what's new now, it's become more and more the standard approach. You can do this surgery in on-pump and in off-pump surgery, and you can now very easily target the posterior wall vessel like the RCA and the posterior vessel. So I talked about this minimally invasive CABG last year, so I'm not going to talk more about that. But as you see, this patient has very nice cosmetic results without opening the sternum, without the invasivity with the sternotomy. In this almost mostly diabetic patient, smoker, obese. The third part of the presentation is the aortic valve replacement. The aortic valve replacement make also a fast-growing improvement in the last years due to the era of TAVI. we do now more and less invasive aortic valve replacement. In the past, we do the mini sternotomy as a minimally invasive surgery. Now it is less invasive and more cosmetic for the patient. The first one is the transaxillary approach. It's very laterally. It's very nice. Somebody calls them the no visible scar technique because it's very, very posterior from the patient. It's a little bit far from the aortic valve, as you see in the CT picture, but it's a very nice procedure. The second technique is the right anterior mini thoracotomy for the second intercostal space anteriorly, which also a very nice and good technique. As you see here, we can use all those stented valves. We don't need to put a sutureless valve and rapid deployment valve. We use the same valve as we use in the open heart surgery. And as you see, we can implant this very nice Edward valve in this patient without any problem. And as you see, here's the very nice cosmetic results of this surgery. The other object is the redo patients. The redo patient, as you know, are the most difficult patient in the cardiac surgery. Most of them are very sick patients. The procedure itself is very high-risk procedure. You have a high tendency for bleeding to open the sternum again, dissect the whole heart and the pleura from the sternum. So can we do this procedure, minimally invasive surgery? It's also make good improvement in the minimally invasive surgery. I want to present you two cases for very sick patient. The first one is this man. He did 20 years ago a mechanical and aortic valve replacement. Come to us with severe TR, ascites, liver dysfunction, renal impairment, right heart failure, and he was so sick that this patient, as you see in the OR, a 10-liter ascites in his abdomen, cannot breathe, cannot eat, cannot walk, and as you see, it's not normal severe TR, it's maybe more than severe. So, as you know, this patient is extremely high risk. If we make this procedure in the classic way, sternotomy, dissect the whole right, very enlarged ventricle from the sternum, high tendency to bleeding due to liver dysfunction. So we do this patient in minimally invasive, beating heart, tricuspid valve repair. So we open the right, so we cannulate the femoral artery, the femoral vein, put the patient on the cardiopulmonary bypass. Also a jugular cannula is needed. And I open the right pleura and open the right atrium without snaring, without manipulation at the heart, at the aorta, at anything. We open just the right atrium and put this ring and closure the right atrium. And the procedure was ended very fast, without ischemia time, without manipulation, with high pressure at the kidney. Another thing is the mitral valve. We can do the tricuspid valve in beating heart with mitral valve. We cannot do that in beating heart. So how we can avoid, again, in patient with redo mitral valve surgery, avoiding the sternotomy, no ischemia time, less bleeding, better outcome. So we had a patient, she was 55 years old, very symptomatic, has aortic and mechanical mitral valve 2012. She presented now with a stuck mechanical valve, one leaflet doesn't move at all, with thrombus on it, with severe TR, the patient very symptomatic and very obese. As you know, this case is also a very high risk patient. So we do this case in redo minimally invasive mitral valve replacement on fibrillating heart and the tricuspid valve on beating heart. At the same procedure, cannulation of the femoral artery, femoral vein, jugular vein, put the patient cardiopulmonary bypass. We put the ventricle on fibrillation, left ventricle on fibrillation, and open only the left atrium. And as you see, after explantation, we put the suture for the mitral valve, and he's the monitor. As you see, the patient is in ventricular fibrillation without cross-clamping the aorta, without giving cardioplegia, without manipulation at the aorta, at the heart. Just open the left atrium and implant a new tissue valve after explantation of the old valve. After we closure the left atrium, we make a DC shock, and the patient is in sinus rhythm. We open the right atrium and repair the tricuspid valve and beating heart. After 24 hours, as you see, the patient had only less than 200 milliliter bleeding in the chest bottle, which was in this patient, if you make it in the classical way, significantly more than that. So we was happy with this result. I think the conclusion is very clear that the minimally invasive surgery become more visible in the last years in very complex cases like redo cases, become more and more the standard approach maybe in years for the CABG. Minimally invasive mitral valve is now is the standard approach in the big center, cardiac center. The minimally invasive aortic valve replacement is really a very promising approach in the era of TAVI and interventional cardiologists. Thank you very much.
Thank you, Dr. Abdul-Hakim. Our next speaker from Palestine. Welcome Dr. Yunis Daralammouri from Palestine. He will talk about coronary artery fistula. Welcome to you.
صباح الخير للجميع. My name is Daralammouri. It's my delight to be here today, and thanks the organizing committee for having me today to present a case. I will be discussing the transcatheter closure of coronary fistula. I am going to present a case. This is a 54-year-old male patient with known case of diabetes mellitus. He presented with exertional dyspnea and angina for 6-month duration. On physical examination, there was a continuous murmur on the left sternal border. The echocardiography revealed a normal ejection fraction. The ECG showed biphasic inverted T wave in V2, V3, and negative T in V4, V5, lead 1, and AVL. The coronary angiography demonstrated a medium-sized coronary fistula from the LAD, probably to mean pulmonary artery, and severe LAD diagonal bifurcation stenosis after the origin of the fistula. The right coronary artery was normal. We performed cardiac CT, which confirmed the termination of the fistula in the mean pulmonary artery. Now, how should we treat this patient? There are 3 options available. The first one is medical treatment. The second is surgical closure. The third one is percutaneous closure. مين مع مين؟ شو رأيكم؟ شو لازم نسوي للمريض؟ مين مع ميديكال ثيرابي يرفع ايده؟ مين مع سيرجيكال؟ واحد. مين مع ترانسكاثيتر؟ مين مع ولا إشي؟ واحد. طيب خلينا نشوف شو الليترشر بيحكي، شو حسوين. First of all, The coronary fistula is abnormal communication between normal coronary artery and another cardiovascular structure. The majority of fistulas are congenital. The prevalence is about 0.1 to 0.3%. The clinical manifestation is very variable and vary from asymptomatic to life-threatening heart failure. The most common symptoms are angina followed by dyspnea, and the symptoms are mainly based on the volume of flow and the degree of coronary steal. You can see here a cartoon demonstration of steal and perfusion imaging. Green represent the fistula, gray represent the coronary artery, and this view represent the short axis of myocardium. In a case of small fistula, the most blood flow is going down the normal coronary artery, and the perfusion is quite normal. Now it is counter distinction to someone that have a large fistula. Now we have steal because the path of least resistance is now going down the fistula. However, if we have a concomitant coronary artery disease on top of that, we have now unregulated fistula going to low pressure system. We get more steal that will cause ischemia and myocardial infarction. Now, how we classify the coronary artery fistula? They are a very heterogeneous group. We can classify the fistula based on the size, whether they're small, medium, or large, depending on the relationship of their size to the normal coronary artery. If large, more than 2, if small, less than 1. Based on the origin, mostly come from right coronary artery, less common from the left coronary artery, and rarely from the both. Based on the segment of fistula origin, this is very important. There is a classification called Sakakibara. There are 2 types, type A and B. Type A, the fistula originating proximally, and the rest vessel is normal. Type B, the fistula originating distally, and the whole vessel will be dilated and involved in the pathology. Based on the drainage side, it can be cameral fistulas, it can be AV fistulas. It can be simple or complex, it can be single or multiple. We have also chronic intrinsic changes such vascular calcification or aneurysm formation. Now, what is about therapeutic decision making? The indication for closure are congestive heart failure, myocardial ischemia, arrhythmia, endocarditis, or arthritis, which described in 2 to 3% in different series. Rupture is very rare, and the premature atherosclerosis is very common. Now here is an algorithm of coronary artery fistula evaluation and management. If the fistula if the fistula is small, you can just monitor the patient every 3 to 5 years. If they are symptomatic and medium-sized and technically visible, and you have no other indication for surgery, you can go for transcatheter closure. Various devices used in the coronary fistula to perform transcatheter closure. These devices include Armblatzer vascular plug, Armblatzer duct occluder, detachable balloon, coils, and covered stent. And these are a comparison of devices used in the coronary fistula. The largest experience that we have are with Armblatzer vascular plug, duct occluder, and coils. And the preferred method for transcatheter closure is the coil embolization. In our case, we decided to perform a transcatheter closure with coils and then BCI to LED. We performed the procedure via radial approach. We advanced a safety wire in the LED here, and a microcatheter was introduced in the coronary fistula. A selective injection showed a whip-like termination of the fistula. So we decided to deploy the first coil in the mid-segment of LED. You can see here the first coils with a significant residual flow. So we decided to employ another coil proximally, and then we did the BCI. And this is the final result after coil embolization and stent implantation. Now, how about the result of transcatheter closure? There are 5 series recently published. The acute successful rate was 91%. However, there were also complications. In this series was the myocardial infarction about 6% and the coil embolization about 7%. To conclude, coronary artery fistulas present with many anatomic variation. Cardiac CT angiography has a critical role in the assessment of the complexity of coronary artery fistulas. Transcatheter closure of coronary fistula is feasible and good alternative to surgery. Closure is indicated in symptomatic patients with medium-sized and large fistula. Thank you.
Thank you, Dr. Yunis. Our last speaker, Dr. Alawaisheh, known consultant cardiologist in Jordan. He will talk about cardiogenic shock following surgical AVR. Welcome, Dr. Raed.
Good morning. Thank you very much for the great session, for everyone who present today with us. Thank you for the surgeons to accept me to be in their session. And as Dr. Omar Lattouf said before, it is a teamwork. And I think the partnership with the cardiac surgeon is really mandatory. And I think it is the time for the cardiologist to pay back to the cardiac surgeon their permanent coverage for our defects or for our failures. So my presentation with this regard is about this nice lady who had surgical aortic valve replacement. Her history actually starts with that she's a 65-year-old female, active female, still doing her own business. And she has type 2 diabetes, not hypertensive, and complaining of dyspnea. She's actually a mother of a minister and also a mother of an orthopedic surgeon. So a very well educated family. They choose to travel to Jordan to have the operation when they found their cardiologist in their country that she has severe aortic stenosis. Ejection fraction 60%, and the aortic valve area was 0.9, peak gradient 118, and mean gradient 73. She had the coronary angiogram there, and it was showing just mild coronary artery disease and the LAD of 40%. So the decision was this is the coronary angiogram, just have a look to this coronary angiogram, and I will remind you later why I bought the diagnostic coronary angio here. You can see that the catheter selectively goes to the circ or to the LAD, and just a few pictures actually showed both the circ and the LAD together. You can see that just mild lesion there in the proximal part of the circ, and the maximum stenosis at the mid-segment of the LED of 30–40% maximum there. So usually in such a case, we go and maybe here one note here. Look at the takeoff of the left main and the takeoff of the RCA. It doesn't move. Anyhow, the RCA is normal. So the options were there to go for aortic valve replacement, to go for minimal invasive aortic valve replacement, or TAVI. So the discussion with the surgery and the family and the surgeon and the cardiac surgeon, we decided to go for minimal invasive aortic valve replacement, that the patient is active and no need to go for TAVI. She's relatively young, so no need to go for TAVI and just to do minimal invasive aortic valve replacement. So this is what happened, and after finishing the surgery, I was called by my colleague, the cardiac surgeon, that the patient temporarily, just transiently, developed ST elevation and left bundle branch block before getting the TE probe out from her esophagus. So they asked me to join them. I saw the monitor. The monitor showed normal sinus rhythm, no abnormality in the ECG. And the TE just shows transiently just showed that there is a minimal hypokinesia in the septal, anteroseptal, in the septum of the heart, which really can explained by that this is surgical septum or explained by something. So it was just a transient. So we elect just to observe the patient, keep the patient on the table in the OR we observed the patient for 30 minutes. She did not show any abnormality. She was stable. Her blood pressure was stable. Her heart rate was stable. Everything was good. So even this was mentioned to the family. We sit outside and we talk about it, what to do. And because it was transient and we observed the patients for 30 minutes, everything was good. So we like to transfer back or take the patient down to the CCU and keep observing her and going in the process of management as regular as any case, usual case of surgical aortic valve replacement. But once we connect the patient and the CCU to the monitor, we found her that she has very low blood pressure, and on the monitor she has bradycardia and left bundle branch block. So she was in maximum inotropes, all the inotropes that we have in the CCU, in the maximum doses, and her blood pressure did not improve, and it went down to 50/30. So I took the echo, I put the probe in the chest, the heart was barely moving, almost not moving at all, and the valve looks well seated. There is no pericardial effusion, the aorta looks normal. So what happened? I don't know, but everyone was giving up, but I insist to take the patient to the cath lab and to check the coronaries, and I asked to prepare ECMO and to put her in ECMO till we know or to see what happened. So patient was transferred to the cath lab immediately on inotropes. ECMO start to prepare, and this is the first shot to the coronary arteries. This is what I found. I think it deserves a moment of silence and to decide what to see, what to do. Actually, the engagement is very difficult, as Dr. Omar mentioned in the previous case, because actually you don't have left main here. And where is the true lumen and what to do? The left system is already gone and the heart is barely moving. Almost there is no blood pressure, and we need to act very fast. So I tried with the Follis catheter, Just any wire, I have the floppy wire, the usual wire, the workhorse wires that and just send it there, where to go. Another wire to send it there, where to go. I'm not sure that even now, even while the wires are down there, I'm not quite sure that I'm in the right lumen or the false lumen, because I can't see anything. There is nothing to be seen. So what we do actually in a situation like this is I went just with low profile, long balloon, just to find out my way. Am I in the right lumen, the true lumen, or it's false lumen? I did one in the LED, one in the circ, just to see. And this is what, after inflating the balloons, you can see that there is the dissection there, extending down in the circ, down in the LED. I don't know where are my wires, because you can see the extension of the dissection is all over there. I don't know where is it. So this situation, now it seems that there's some flow there. The heart starts to move. The intra-aortic balloon pump is there. I don't know what it's doing there, but at least this is what I have at this moment. We need to act very rapidly. And this is what I did. Get the aspiration catheter, try to aspirate the clot from there. Even if I'm in a false lumen with the aspiration catheter, we do as in what we do actually the STAR technique in CTO, where we aspirate the hematoma. If there is hematoma in the false lumen, at least I aspirate it. At least I aspirate any clot there, just to find my way, where is the coronaries, because other way you can see nothing. So this is what I see after doing this. Now there is some hope that maybe my wire in the left circ is in the true lumen, the right channel, the right direction, where it goes to the OM, and there's the circ is there. The LED, I'm not sure still where is it exactly. What makes me more comfortable with the circ, that the wire that you can see there in the OM2 can easily go by gentle pull back to OM1. So once I saw this, that my wire can go to the two OMs simply without resistance, so I know that I'm in the true lumen, at least in the distal part. Maybe my wire there going in and out between the true lumen and false lumen, and this is okay, it's acceptable, that distally at least I will save the two OMs. So this has encouraged me to put the first stent. I put the first stent in a way away from the bifurcation of the left main, also away from the bifurcation of the two OMs, just to hold that area, and then we decide what to do. Because my purpose at this time is not the position of the stent as much as getting a flow to one of the main vessels in the left system. And this is what I achieved. Stent is there. Now there is some control there. You can see that the dissection even going there to the OM, down to the curve, but there is dissection. You can see that the stent in the left circ doesn't cover the ostium, and there's something there, but it's not my care. I don't care for this at meantime. I want to flow. The LED, I don't know. I cannot see the LED. I don't know about the wire. I rewired the LED, tried to do manipulation. The maximum I did is this. And to confirm that in the true lumen, I used the aspiration catheter itself after cleaning it very well, and I did the injection in the LED. And you can see, as you can see here, that the contrast in the true lumen. So really, I took a deep breath right now, that the LED now in the true lumen distally. So the LED, I can put a stent there, and the same way, getting flow back to LED. Doing all of this, now I can correct all what we did and to manage the stents to survive for a quite long time. At the moment, the heart starts to move, the pressure starts to pick up, the team start to relax, and I start to go with doing the good PCI, go to the iliocranial, getting the ostium of the left main, put an overlap stent between covering the ostium of the left main, overlap with the stent in the LED, successfully done, and you can now see the left main in a better shape than before, and it is time to correct the stent in the left circ. So I did the tap technique, with tap technique, finished with the kissing technique and all the techniques that we know as interventional cardiologists. Both final case, everything's there, and the left system returned back correctly, everything is fine, and even if you look to the bifurcation of the two OMs, looks nice there.
Time over.
And happily ever after, I think the patient has been saved. And now I can take a shot for the RCA. Now I took the shot for the RCA, and you can see the RCA is good here. And this is the follow-up. After 2 days, the patient was extubated, all the instruments were removed, and after 7 days, she was discharged from the hospital. And 2 months after that, I had a call from her son that she returned back to drive her car. And this is my conclusion, just to conclude here, that iatrogenic coronary dissection during aortic valve surgery or any surgery is a dramatic complication, and the diagnosis is difficult, very difficult really, especially that the patient is intubated and cannot complain. And the coronary angiography should be performed after exclusion of the aortic dissection or problem in the aorta of the clamp or whatever. And percutaneous coronary intervention could be difficult, really difficult, but the most important challenge is to find the true lumen and to go from there. Thank you very much.
Thank you Dr. Raed. يعني اللي وفر الدكتور عبد الحكيم أخذته أنت وقت. Door open for discussion. Any question for the speakers? Dr. Asim.
Thank you. أعتقد أن الحضور أكثر من 95% عرب، لذلك اسمحوا لي أتكلم بالعربي عن التيم وورك. الله يرحمه دكتور سهيل صالح، لما كانوا الجزائريين يبعثوا لنا حالات صعبة جدا second, third and حتى fourth redo، فكان يقول لي أنا كنت شباب شوي لسه، هو يقول لي يا عاصم أنت شباب ابدأ وأنا بكمل. فكان فعلا تيم وورك، العملية تأخذ 6 ساعات إلى 7 ساعات، أنا أشتغل منها حوالي 3 ساعات، أحرر الهارت، أحط له الكانيوليشن وهو يكمل الباثولوجي. بعدها تيم وورك تاني، إجا الدكتور عمر لطوف من أمريكا، قرر يرجع، فقال لي يا عاصم التيم تبعنا لازم يستمر، واستمر التيم حتى اليوم بالمساعدين والممرضين والبامب التكنيشنز. فالتيم وورك هو الطريق الوحيد للنجاح. شكرا.
أتفضل عاصم.
أنا سؤالي للدكتور اللي قدم الفيستولا دار العموري.
دكتور يونس.
يعني أنا I have zero experience with the fistula، بس يعني I would think that it would be easier if you put your stent first, especially the LAD's disease, and go with your microcatheter via the struts and close the fistula with coils.
Yeah,
that would be safer for the coils not to slip back.
في طريقة بيسموها stent assisted coiling، هاي بتسويها إذا كان ريسك إنه يصير يطلع الكويس لل LED. بس في الحالة هاي حطينا الستنت الكويس في البداية very distal، فالاحتمالية إنه يطلع برا قليل، وبعدين هاي كانت detachable coils، فبتقدر أنت تتحكم فيها كثير. إذا كانت النك تبعت أو الأوريجين تبعت الفيستولا large، فممكن نسويها assistant coiling، تحط stent assisting coiling، تحط stent تدخل في الميكرو كاثيتر وتسوي coiling للفيستولا. بس في الحالة هاي الريسك إنه يكون هيك احنا بنسويها detachable، بس حتى لو مش detachable الريسك إنه يصير retrieval للهاي قليل جدا جدا.
Thank you.
هلا فيك.
Any question?
طبعا I don't have a question, I have a comment. طبعا الحالة اللي قدمها الدكتور رائد كنت أنا مشتغلها ومبسوط جدا. English? Okay. I was very happy that I did the case. The patient was in good condition, but we saw this very small changes, very small symptoms, and we decided not to do anything and go back out of the OR. But to see the patient half hour later, cardiogenic shock, a very bad blood pressure. His son is a doctor beside her bed and look at his mom, and we almost give up and think we cannot take this patient to OR again. It's too late now with blood pressure about 40 to 20. So this decision to take the patient to the cath lab was صراحة قرار شجاع جدا, and to treat this patient in this way. After all these things, we was not so optimistic that this patient will survive this whole procedure, but the patient survived this procedure. So my comment is, I learned a very big lesson from this case, not to give up even if you say that this patient is a so poor condition that he almost dead. And the case of Dr. Omar is the same case almost. You give up almost. A cardiologist say, I will not come for this case, treat him medically. He did 3 times today. So we don't give up. We make this decision together, and the patient survive the procedure. So I am very happy about that. Thank you very much.
I have a comment and a question to Dr. Raed about this case. It's well known that when coronary obstruction happened after TAVI or after SAVR, it is always a disaster. And at this stage, death is imminent. If you don't do anything, death is guaranteed 100%. And if you do successful procedure, you will get around 20 to 30, 50% actually mortality. But in this case, right, and looking at the first shot that you did, it was obvious that the left main is dissected. So the standard teaching, if you have very, very proximal at the ostium of the left main dissection, why not you did not start with trying to close the entry of the section and putting a good stent at the ostium of the left main from the start. Maybe this will help you later on working down on the circ and the LAD.
Good question. Good question. You have a point. This is, as you can see from the first picture, I see nothing. I don't know where is the true lumen, where is the false lumen. I have another cases where, as you know, we have the catheter-induced dissection. In this problem, when you have catheter-induced dissection, what we do, I have another case, we can I don't know, I was planning to present yesterday. In this case, I bring another catheter in the left main, beside the catheter, the original one. I keep the original one in there because I know it is in the false lumen. And by the true catheter, or the second catheter, I go through lumen, go distally there, and fix the left main, the first thing to do. This is usually what we do. In this case, this is really exceptional. It is first time for me to see something like this. And we don't know that the wire, is it in the right lumen, in the false lumen, the true lumen? Where is the wire? I don't know. So in this case, I elect to go from distal to proximal, not from proximal to distal. Because also another cases we faced that the wire comes in and out between the true lumen and false lumen, true lumen, false lumen. And if I put a stent in the left main in the false lumen, or very proximal in the LAD, or I close the bifurcation of left of the LAD and the circ, the disaster, I will finish everything. Everything will be obscured. There will be no flow distally, and I think the result will be very, very, very bad. So I elect to go from distal to proximal instead from proximal to distal. Thank you very much for the good question.
أنا برضو عندي سؤال لرايد إذا اسمحوا لي. يعني الwire being proximally or mid in the false lumen doesn't matter if it is distal in the true lumen. The most important part is being distally in the true lumen. So in such a case with يعني crashing patient, left main, or it's a very short left main, it's almost separate OSTI.
Yes.
What I would have done, I would have taken 7 French guys from the beginning, taking 2 simultaneous stent, 1 long in the LED, 1 long in the circ before the bifurcation, and inflate them simultaneously. And a simultaneous casing stent or double barrel stent has a bailout in a shocked patient with a left main, especially if you don't have time. But يعني, the end result was great, and I congratulate you.
Yeah, thank you very much. Again, the point is here we need to act very quick, very quick, and to act in the right way, the most secured way, the most right way to do it. So I have a case where distally, as you said, distally we added the true lumen, and I fixed everything proximal. Next day, we came back totally occluded, and we found out that the wire was distally, but it was in and out. I have presented this case also in another conference before. So I like this way to be the best way. Maybe this one also will work.
Great case, Dr. Raed. Congratulations and great save. Just a couple of questions. In these cases where you don't really know where you are, where your wire is, you have really difficulty visualizing the vessel, do you have access to intravascular imaging, intravascular ultrasound, knowing exactly where your wire is? My second question is, I saw that you were ready to put the patient on ECMO. Is there a reason why this wasn't initiated early? I mean, this was great. I mean, you did the whole case. I see that you put a balloon pump maybe towards the end of the case or so, but is there a reason why you didn't start from the very beginning? The heart was barely beating. It would have made, your PCI simpler and safer, probably. Yeah,
I'm sure. I should remember one thing. In this patient, everybody, when we were in the CCU, they say, "What the hell are you doing? Why do you want to take the patient to the cath lab?" بصراحة حتى يعني بالعربي نحكي بالعربي. قال بدك تقرأ عليه الفاتحة فوق خلاص نقرأها عليه هون يعني something like this. The point is, even to ECMO, to prepare ECMO, to bring ECMO, to start ECMO, to get the machine, there is no time for doing all of this. Even for intra-aortic balloon pump, but if you notice from the views, to start after. So the first thing was for me is to return flow. And as you know, returning flow to the heart is the most important thing to do, more important than any support. I know there was a qudra ilahiyya. It is the hand of God actually saved this patient. It is not pure just a person or a team or whatever. But really, the most important thing I think at this moment is to return the flow.
Last comment from Dr. Bahi.
I have a question to Dr. Omar. How often the minimal invasive procedure is used in CABG surgery in the States?
My partner, John Puskas, performs, and my other partner, Michael Halkos, perform robotic-assisted coronary artery bypass with a left internal mammary artery to the LAD primarily. Others will do a left mini thoracotomy and perform multi-vessel. I would say overall, the incidence of minimally invasive non-sternotomy coronary artery bypass is probably very small. I think you're looking in a single digit. It's not really very large.
ممكن أسأل سؤال دكتور عبد الحكيم دي بالنسبة للمينيمال انفيزيف اورتيك فالف ريبليسمنت في كونترا انديكيشن ولا جميع المرضى ممكن يزبط معهم مينيمال انفيزيف؟
يعني all patient can be done in minimal invasive. We try not to do very obese patient. Very obese mean very obese, 120, 130 kilo. Yesterday I did one, but not damn it after I did that. It's very difficult to do aortic valve, especially aortic valve in very obese patients, because you have a short distance to the aorta and very big distance from the skin to the chest, and it makes the procedure a little bit difficult. But almost in all, we do 90% of our aortic valve replacement in minimal invasive.
Thank you all. We end the session.
What happened in this case, we are not sure, but we did something called direct ostial cardioplegia. That means I take a catheter and put this catheter in the left main and in the right coronary ostia and give cardioplegia. So maybe it's the reason for this late dissection, a small injury, and It's take time, maybe 1 hour after the thing to make the dissection. That could be a speculation, because if we make the dissection in the OR, the patient was not able to go out of the OR with this stable changes. Maybe it's small injury and make the dissection 1 hour later, and the patient began to be very unstable.
Omar.
You know, a word of caution. We cannot make general statements based on one case. With all due respect, Dr. Raed, and I congratulate you on your work. If you were to take 100 cases like the one you do, and if you do not put them on ECMO, your mortality rate is going to be high, and you will be out of business. If a patient presents with such a situation, I think the guidelines would strongly encourage you to put that patient on ECMO. Data shows that when patients are in severe heart failure, ECMO will pull them through. You may have done a good job on this one, but don't take it as a practice.
I would like to ask you, Dr. Omar, in the United States, in the center that you work in, how long would it take connecting the patient to ECMO?
8 minutes. Well, you know, that's a strategic question. And increasingly, centers are having ECMO and are deploying them. Just as long as it takes you to get the cath lab team in, when you decide that you want to take a patient for a cath procedure, you notify the ECMO team and your surgeon, and everyone else must come. So it does take preparation, and it does take strategy, and it has to be done. But when you look at a system of care, I think plans should be made where you have an entire team capable of providing care. It takes time, but, you know, plan it.
Every second was of value in this patient, so getting all of these teams and all of these for ECMO to connect the patient to an ECMO in our centers in Jordan, it will take, I guarantee you, it take longer time than starting doing the intervention.
Thank you. It's time for a coffee break. We end.